suggestions for primary care in early diagnosis?
Okay. Well, first, and thank you for coming. I know most or near all of you, and I'm Luciano Costa. I'm a myeloma physician here at UAB. I also want to acknowledge that Caitlin over there. Caitlin is our nurse practitioner, and I'm glad that she came to. And if there's any question I cannot answer, she can. And to Todd's point, there's nothing that I would rather do than spending the Saturday morning here with you. The other options were laundry and clean up. So I'm double grateful. I think if I understand correct, I think your question is about early detection through the primary care physician. I know nothing about sports, but I learned after 20 years in this country the meaning of Monday morning quarterback, and we're used. No, is that how you say it? Yeah. Yes. Monday morning. Yeah. And we are often that, right? We see somebody who clearly had the symptom that would connect it to myeloma, and they got missed multiple times over. So it's easy for us to say, well, how come they didn't see, right? But the other side, by the time people come in our office, somebody already suspected, and we got a little bit of tunnel vision. That's all we see. When you're the primary care physician, for every back pain that they see that is turned out to be myeloma, they're seeing 99 others that turn out to be just back pain. For one anemia that they see that turned out to be myeloma, they're seeing dozens of others that are, nutritional deficiency of iron deficiency. So how that can be done is really in education, and I think a part of what we do is not only educate specialists, but also educate physicians in training. About some tips, some clues to where to suspect. Some red flags of when to suspect myeloma. So, somebody who never had back pain now has back pain, and you got to do image at some point. Anemia that is not otherwise explained. And particularly on an older adult, to make sure you test for the protein electrophoresis and the free light change that allows to screen myeloma. Renal dysfunction that is not otherwise explained, and so forth. There's the flip side of that is, also over testing. A lot of what Caitlin see, for example, are people screening for myeloma in situations where they shouldn't, and they come up with spurious test results, and the patient gets to us very, very concerned for something that they shouldn't be. So it kind of goes both ways. There is some interest in screening, right? If you have, we all hear about the success for breast cancer screening with mammograms, colon cancer screening with colonoscopy and so forth. And it's, the next thought is, why should we screen people for multiple myeloma? And that's a very intuitive thought. Let's detect early to do more. And but for every screening, there is a counterbalance, which is the risk of overdiagnosing. In other words, identifying normal findings in people who would live their full life without ever have a problem. It now generates concerns, additional tests, and invasive tests, right? And that exists for every cancer, and exists also for myeloma. And we all heard about the concept of smoldering myeloma and MGUS. So for every patient that we see with MGUS, there are dozens out there who have MGUS, don't know, don't need to know, and will live a whole life without knowing. Then when you start screening, you start finding those people, creating uh, concerns, creating um, invasive tests and more interactions with the healthcare. So it's not a foregone conclusion that screening would improve outcomes and save lives, so to speak. There is a study, a large study going on in Iceland, which is it's called I-stop myeloma. That is a population-based, the whole country. I think they have more than 50% of the population involved, which is incredible. Where some patients, some people get screened, some people don't, and they're really, um, testing someone about, do we really find it early? Do we really improve people's life? Do we usually improve survival? Because we gotta think about it, cancer is just one threat to people's survival. And myeloma is 1% of the cancers, right? So the bar of say, I'm gonna do screening for everybody, and that's gonna change people's, survival on a population level is a little bit tricky.
Pharmacies are pushing, giving the vaccines.
Just quick for those online, she's asking about vaccines and if you should get your COVID vaccines and your flu vaccines should be taken at the same time or at different times. Just so that's the question.
Yeah, so the answer is yes, yes, and yes. So it's really sad that the vaccine became something suddenly controversial and political, as opposed to being what it's supposed to be, is something very data driven. There are risks associated with COVID vaccine, as there are with flu vaccine. They are extremely minute, extremely minute. And in the case of COVID vaccine, that was mostly in young men. Now, the benefit of the vaccine was, I think got, again, politicized. I think at the time of the top of the pandemic, the benefit was exaggerated by one group of people and was and dismissed by another group. And when the truth is probably somewhere in the middle. Now, the vaccine was very effective in preventing serious illness, right? And the reality is we're in a different type of the pandemic where serious illness is rare to begin with, right? So let's say the benefit, the impact of the vaccine is probably less now than it was in 2021, right? Because the people are not getting as sick because it's a different type of the pandemic. Most of us have immunity already from prior vaccination, from prior exposure. So the gain with the vaccine and the risk of omitting it is not as great as it was 4 years ago. That being said, the people who get sick from COVID nowadays, they exist, they are usually patients who are immunocompromised and people who are older, right? And the majority of patients who live with myeloma, they are both older and immunocompromised. So that's a prime group that should be vaccinated. And the risk, so to speak, is minimal to non-existent for this population. Now talk about 19-year-old athletes. I think for any, something is sometimes not a very intuitive concept, but for every medical intervention, you have the idea, think about this, the idea of the number needed to treat. In other words, how many people I have to vaccinate to prevent one hospitalization, right? And something called the number need to harm. I mean, how many people I have to vaccinate to have one myocarditis, okay? And when you talk about a young person with very low risk of getting sick and a slightly higher risk of having toxicity, it's probably not the right balance. But when you talk about the older individuals with, with multiple myeloma, the number need to treat is way smaller than the number need to harm, right? In other words, the pros greatly overcome the cons. Okay. Flu is the same thing. The risks of flu are less discussed, but it's rare neurologic things, something called Guillain-Barré syndrome. I never seen one related to vaccines. Again, tend to have more in the younger, more in healthy individuals. I think I think in our popular culture, we got the idea because of the success of polio, right? Remember, it was a devastating disease that got eradicated by vaccines. And things like variola and things like this. The vaccine needs to be infallible, right? Because we got rid of polio overnight, almost, right? Because we had a vaccine that was 100% effective and 100% safe. But in reality, those examples are the exception. There are very few success stories like polio. Most of what vaccines do is reduce the risk of serious illness. Okay? And that reduction is not anywhere near 100%. And with flu is particularly important because the virus changes every year. It's a virus that mutates very quickly. So right now, we're in the 25-26 season. There are people there collecting flu samples to see what is around this year. And based on what is around this year, we're going to make the vaccine for next year, which means the vaccines we're getting now are based on what was circulating 12 months ago. So sometimes the vaccines don't work because they're not infallible and because the virus changes. But it's well established that if you're vaccinated, you greatly reduce your risk of having serious illness. And people who get sick and get hospitalized, and unfortunately the few people who die from flu, are usually older, immunosuppressed people. Okay? So yes, everybody should get the flu shot. Everybody living with myeloma should get their COVID. And there's no problem taking it at the same time. Our immune system is incredibly smart and dynamic. And having one vaccine does not confuse your immune system for the other. Okay? Does it have to be the same day? No, it doesn't. But if you happen to be at the pharmacy, they offer you both. Take both.
Is there any advantage to being older and immunocompromised?
An advantage? only if you are rich or wealthy, so it increases with age. That's the only good thing.
Doctor, how many clinical trials are you?
Yeah, that's a great question. I think many of you are participating or have participated in clinical trials. Clinical trials are essentially how we advance the field. The reason why I spent most of my professional time, which happens to be most of my time, dealing with clinical trials, is because it's such a straightforward proposition. It's something that the patients win, the knowledge wins, and advance our institution, advance our careers, but most important, advance lives for the patients. It's which is the magic of this field is that you can do good for patients, can do good for themselves. We can do well for the patients, while you're still generating knowledge, right? And that's what clinical trials are. And I think there's a lot of, some of that, of course, I'm preaching to the choir because many of you have been involved and are very knowledgeable people. But, there's a lot of misconceptions about clinical trials. And what I tell people is, clinical trials are treatments that are at the same time treating the individual and generating knowledge. And those things are not conflicting at all. The analogy I make to patients is, you need to get on a plane and go from here to, Washington. And you want to have a very good pilot, no doubt about it, which is your doctor who's going to, help you, guide you there. But also you want to have a good, flight plan. And a clinical trial is not one or the other, it's both. You have, when you are in a clinical trial, the decisions are not being made only on the knowledge and judgment of the doctor that day. It's the knowledge and the judgment of the doctor that day, plus at least 4 other layers of people who have looked at that flight plan from the optics of ethics, from the scientific optics, and from the regulatory optics, right? So before any clinical trial is in front of you, being offered to you, there is a body of our peers who thought that was scientifically sound. We don't want to offer to people things that are silly or not going to advance the knowledge, that are ethical. So you're not leaving any money on the table. We're not leaving out established therapy to do an unproven one. Okay, and it also fits the regulatory requirements. There's the proper oversight. There's proper monitoring, right? So it goes through the scientific bodies at the institutions, goes through the institutional review board at the institutional level, goes to the FDA. So everybody signs off before something is offered to you. So as any academic institution should do, we have a number of clinical trials at UAB. Currently, we have 16 accruing clinical trials in myeloma, ranging from people with newly diagnosed myeloma, asking very important questions. For example, does everybody needs a transplant, or is there a group of patients who have a good enough response after initial therapy who can forgo transplant? Okay, does everybody really need treatment forever? There are some milestones that can be achieved that, if achieved, can identify patients that perhaps do not need to be on treatment forever. And 2 questions for people who have disease that has returned. We all heard about the excitement about CAR T-cell therapy and bispecific T-cell engagers that are really now transform the field when you're dealing with disease that has come back. But I'm very convinced that what we're doing now, even though it's jaw-dropping in terms of what we had just 5 years ago, is only the first step, is only the first era. And we are working now on T-cell engagers and CAR T-cells that are now going after multiple targets of cancer cells opposed to just one target, with better schedule of administration, better safety profile. We have trials that are using, oral agents on, for those of you who have heard of or been taking Revlimid or Pomalyst, drugs that are like 2 generations up from those in terms of what they do with the cancer cell. So I think it's impossible to get a day when there's a clinical trial for everybody, but we certainly will aspire to have a clinical trial for as many people as possible. And nowadays, at UAB, myeloma accrues more patients to clinical trials than any other cancer. Breast cancer is what, like 15 times more common? Lung cancer, 20 times more common? But we still have more patients accrued to clinical trials in myeloma than any other disease, because our entire group, pursues that very, passionately.
Speaking of clinical trials, I think this is appropriate for most people. The CAR T cell, that's, everybody talks about it now, that's always the first line conversation. And I would have been interested in a clinical trial based on some of the data I saw, but now it's a standard therapy. I've read some where people are now trying to push it as the second line. So you're in your first line of therapy. Is CAR T now going to be the second thing that happens once you come out of remission?
Yeah, great question. So to set the stage, CAR T cell is a treatment where we collect from the patient's blood T cells. T cells are part of our immune system. We all have T cells floating around our blood. And what T cells do is they are specialized in killing other cells. Why do we have that in our body? Because that's one of the way our body deals with invaders, deal with infections, right? So for example, if we get exposed to a virus, I'll give an example. We get exposed to a respiratory virus, like I probably had last week. And the reason I'm now still coughing ever here and there is because there was some damage to the inner part of my airways that it was in part caused by my T cells. The virus invades the normal cells. That's what it needs to do to replicate. And your immune system suddenly see that cell is making some proteins that are not self. They're not mine. And that is the signal for the T cells to engage and kill the cells. So the T cell has all the weapons to kill another cell. Well, why it doesn't kill myeloma? Well, because myeloma is a normal cell that got corrupted. So, the myeloma is a plasma cell, so has all the same proteins that a normal plasma cell. It doesn't have anything to tell the body, oh, I'm strange and I should be targeted. So what CAR T cell is to gain that system, to now make the T cells engage and kill the myeloma cells. So how is that done? We take T cells from the patient. They go to a process called manufacturing, where those T cells are purified, expanded. Now we have more of those, and the word is transfected. Essentially, there's interesting about a virus that carries into that cell a receptor that now identifies a protein on the myeloma cell. And for the CAR Ts that we have available now, that protein has to be BCMA, okay? So at the end of 4 to 6 weeks, we have a batch of cells that are, are personalized. They came from that patient, so it is unique to that patient. And those T cells now have a receptor that can identify the protein in the myeloma cell. Well, then after some chemotherapy, which is relatively mild to prepare the immune system, those cells are given to the patient through an IV. And in the body, they expand, they grow enough, they multiply. So this has been called sometimes a living drug, because you end up with more than you had. And those cells are able to track the cancer, bind the cancer, kill the cancer. Okay? So it's an extremely effective way to kill myeloma. Has some problems. Now, there are some side effects that can come short term. It's something we call cytokine release syndrome, like fever. Sometimes can be drops in blood pressure, problems breathing. That happens because of the, exaggerated immune response. And there are some other problems that are a bit more concerning, particularly neurologic problems. Some people, even 1-2% of patients, develop a movement disorder, like Parkinson-like syndrome. So when this treatment started, we had that in clinical trials since 2018. The first approval, I think, was 2022. Was like last resort, okay? Like you had all the drugs, nothing else worked, you do CAR T cell. And now trials have been done that compare CAR T cells against established therapies that people get as their second and third therapy. And those trials have been very impressive. The one that mentioned, it was essentially a study called CARTITUDE-4 that took one of the CAR Ts that is out there now called cilta-cel and compared that with a couple of regimens, including daratumumab and pomalidomide, and showed that the patients who get CAR T, they have better responses, longer lasting response, and better survival. Okay? So it's very impressive therapy. It's not perfect therapy. And that study had patients who had anywhere from 1 prior therapy to 3 prior therapies. So that generates a lot of debate. Should people get that as their second therapy? And the answer is, it depends. On that trial, the people who received CAR T with second-line therapy are patients who had disease progressing on Revlimid, and that progression was happening in the first 3 years from diagnosis. So those are patients who have high-risk disease. It's a disease that is coming back, that is growing right away, and is resistant to one of the most important drugs that we have. So if I have a patient with that profile, Revlimid refractory myeloma, developing the first 3 years, then yes, we do recommend CAR T cell. If I have a patient who has myeloma and that was diagnosed 8 years ago, and now it's progressing on year 8 or year 9, we don't know if CAR T is beneficial to that patient. Because the risk stays the same. The benefit is probably less because the other therapies are likely to be effective as well. So it's a bit of a sticky point. Now, there are other therapies that are quickly being developed that I think will challenge this notion that everybody on second line should get a CAR T. We also heard about bispecific T-cell engagers. So those are, the end result is similar. We want the T cells to kill the cancer. But instead of taking the T cells, manufacturing the T cells, waiting for 4 weeks and get back, we give a shot of an antibody that now makes a connection, okay, between the T cells that are flying by and the cancer, because they have an affinity. They have a glue to the T cells and they have a glue to the cancer. So they make that connection. And those therapies are incredibly effective as well. And they are now available for patients who had 4 or more treatments. But the clinical trials in earlier lines have been done. And the one that will first give us results was announced this week as a press release that improve progression-free survival and overall survival. So I think we're going to have to see that data and compare, but that offers a safer and more accessible T-cell redirected therapy to people as early as second line of therapy. So sorry for the very long answer, but today I think is appropriately second line for patients who fit that profile.
but there are other options that come down the road.
Just follow this. So you're saying CAR T, second line for high risk, so high risk means age 17.
No, yes as well, but I'm talking mostly about the timing of progression. The timing of progression.
So how fast?
Yes, because the population that was included on the clinical trial that gave us that evidence were people progressing in the first 3 years, right? So I cannot extrapolate this to somebody who is progressing after 9 years. Risk is something important, but it's not something that is static, right? Let's say you get diagnosed with myeloma and you have 17p and translocation 414. You're considered a high risk, okay? Well, you get your treatment, you have a good response. Now you are 7 years, later, and you're fine. Well, I'm not so scared about your myeloma anymore. But then you have the person next door who was diagnosed with standard risk myeloma, got the treatment, got a response, and despite getting the same treatment, the myeloma is back on the 2nd year. I'm scared of that one. So that's often called functional high risk. And all that does is tell us the notion that there's no risk system that is perfect in predicting how people are going to do. And risk is something that is modifiable by the efficacy of our therapies. I like to say that, if you go back in time 20 years ago, myeloma was high risk because the therapies were absolutely horrendous and didn't do very much. I think as the therapies evolve, we're constantly revisiting the classification of risk. I'll give you an example. One particular chromosome abnormality is called translocation 414, okay? That was regarded 15 years ago as high risk. And with the evolution of therapy, that is now very well demonstrated. It's not anymore. Those patients do just as well as the standard risk patients, so long they receive therapies that include proteasome inhibitor, like Velcade or carprolis, and most people do, and particularly now with daratumumab. So that idea of risk changes over time.
So I know the treatments have made this tremendous progress over the last 10 years or so. I've also heard, I don't know if this is true, that myeloma is making people at younger, we're seeing more people at younger ages. So I'm wondering if that is true, and if so, are there any theories for that or is it actually happening?
Yeah, a good question. We think it's more of a detection thing. The incidence of myeloma is increasing. Some of that, very small part, might be real. It's hard to separate that out. A lot of that is kind of early detection, because blood work. Nowadays, if you go to the doctor wants to know your kidney function. Instead of ordering the kidney function test, they order a panel, and you get the answer for the question you asked, and 10 other answers for the questions you didn't ask, right? So oftentimes people spot slightly high protein, right? And then they say, oh, what is this? Let's do electrophoresis from the name spike. So there is, even though there's no population-based screening, there's this accidental early detection because of multiplicity of blood work. So that causes some people being diagnosed sometimes earlier in life than they would otherwise. There's two ways to look at this. One way is, okay, it's good to know early, so I'm prepared and know what to monitor. The other way to look at this is, okay, now I'm worried for 5 years sooner than I would otherwise, okay? There's of course the peak. Most people, the average age of diagnosis is 70 in this country, and is younger, is earlier in Black Americans. And I think there's a bit of a debate. I don't think that is necessarily because the disease is different. It's just because the Black population is younger. So is the Hispanic population, right? And people have looked at, biological difference, different responses therapy. And there isn't any that we can, rely on. In general, younger people do better with therapies because therapies, for the most part, were developed in clinical trials that include the typical patients in their 60s and 70s and 80s. And when you give that to a 40-year-old, they handle just fine, right? So in general, younger people tend to have an easier time with therapy, have better responses, have better survival. But that probably has more to do with, being younger and fitter and having less other medical problems than an intrinsic difference in the disease biology.
Any other questions?
So can you speak a little bit about once you're on maintenance, the current types of like supplements or things like that that you can recommend, like supplement the blood, these things about things like specifically to kind of increase energy, increase your immune system and things like that. And sometimes I'll look something up and it's got results. And
Yeah.
like I look to be as healthy as I can.
Yeah.
As a vegan, but I'm always afraid to,
Yeah.
to go to something.
So great question. So lifestyle, it comes down to, food supplements and lifestyle modifications, right? And I think it's one of the most, one of the things patients ask the most, one of the things we know the least, okay? And the reason why people ask about this, because you had your life torn apart by this disease. Now you go from being, a professional, a father, a mother, a grandfather, and now you have to take a good chunk of your time and your attention to be a myeloma patient, right? And you go into you got through this vocabulary that you never heard about before. Induction, maintenance, bortezomib, daratumumab, and all those long, messy words. You go from doctor to doctor. A lot of things that you don't know about, you have no control over, you're lost. And say, what can I do, right? And people relate, well, the things that I can do is what I eat and what exercise do I do, what food supplements. So it's something that is very relatable to people because those are things that are on everybody's reach. But nutrition and lifestyle changes are very difficult to study. Because let's say I want to compare drug A, drug B. Well, we do a clinical trial, half patients get drug A, half the patients get drug B. And I know what they're getting, I know when they're getting. I measure the results on their blood tests. Very clean. Now I'm going to do an intervention about, nutrition. I don't know what you're eating, right? And the effects of that are going to be, in a way, supersede or masked by what we're doing for the cancer, right? Because, none of us is believing that what you eat is going to, by itself, take care of the cancer or how you feel, right? So it's very difficult to do. There's some early research about plant-based nutrition. There's a physician in New York who's making a career out of this, to her credit, on how plant-based nutrition might have some important effects on your immune system, maybe help people prevent from evolving from MGUS to smoldering, from smoldering to myeloma. But it's very early, very it's very early and not definitive. So my suggestion to people is you know, it's already hard to have a cancer and to take the treatments. So don't make everything else too hard, right? We don't want to dismiss these lifestyle changes, but we don't want you to be 100% of your time consumed by concerns about what I'm going to eat and the effect it's going to have on our cancer, right? Those dietary changes, those food supplements, those lifestyle changes, don't worry about the effect they're going to have on the cancer because that's probably minimal to none. Think about the effect they're going to have on your well-being, okay? And at the end of the day, you want to do things that make you feel good, right? If you tell me, if I tell me I have cancer and I'm going to have to take this chemo, and I'm going to be, you know, I cannot eat my yogurt every morning or my what do I like, my fish or whatever, I'm going to be more miserable, right? So you know, it's more about things that affect your quality of life, affect your well-being. I think exercise is something, again, do as I say, not as I do, but exercise is something that is overlooked, has a great impact on well-being. Sometimes it comes with some myths like, oh, this is a bone cancer. I cannot do anything physical because I'm gonna break. And no, unless you are, you know, going to the gym and trying to lift 150 pounds, you'll be fine, right? With aerobic exercise, you're doing fine with water exercise. I always tell people that's great. That gets most of your body moving. It's easier on your joints. It's very healthy. In terms of nutrition, you know, a well-balanced diet. I always tell people to, if you can, cut down the carbohydrates. Not because it's going to be bad for the cancer, because you're already taking things like steroids that cause weight gain, can cause increasing blood sugar, blood pressure. Carbohydrates can do that as well. But to have a regular, healthy, no carbohydrate diet. And I usually tell people take a multivitamin. You know, if you eat an average American diet, you're getting 300% of every single nutrient that you need. Okay, but you know, sometimes you have diarrhea from this medication, or you have you know, or you're not eating well for a period of time when you're going to a certain phase of your treatment. So take your multivitamin. It's something that, you know, worst case scenario is harmless. You know, you pee out the excess of the vitamins. And best case scenario prevents you from becoming deficient on one thing or another. Just take a regular, you know, multivitamin. There are a lot of things out there about turmeric. What is the new one? Haley, help me here. Things that people are taking these days. Or yeah, supplements or even drugs. There's the malaria drug that people start taking. What is that? Ivermectin. I mean, those things are, you know, they don't. I mean, I can say categorically they don't have any proven benefit. Okay, and some people in the medical community get really defensive and upset with patients when they say, I'm taking turmeric, I'm taking. I mean, and at the end of the day, my concern is, are you taking are you taking what it needs to overcome to deal with your myeloma? Yes. Will this harm you? If I don't have any evidence that it harms you, and you want to take, I mean, I'm not gonna be dogmatic about it. Okay?
If bacon makes you happy, eat bacon.
Yeah, if that's all you got, that's fine.
I have high risk smoldering myeloma. From the trial, we have 6 months and 2 years. I was not in that trial. Can a doctor prescribe for my smoldering guidelines, and they recommend progresses.
Yeah,
And those specific.
Yeah.
Drugs and treatments.
who's your doctor, Emery?
Nuclear pulse.
Oh, yeah, I know those guys. They're great people. So smoldering myeloma is one of the most controversial things that there is, okay? For those who are not familiar with the idea, smoldering myeloma is when you do have myeloma. It means you have an abnormal protein in the blood. And if you do the bone marrow, you have more than 10% plasma cells. And they are clonal, they are cancerous. They are all copies of each other. But that person doesn't have any problems. Your bones are not affected, you don't have anemia, your kidneys are perfect, your calcium is low. And back in the 80s, a doctor called Dr. Kyle, who's still living at the age of 96 from Mayo, framed this term smoldering myeloma to tell those patients should not be treated because they're not sick and they can be watched for many years without having problems, okay? And that to this day remains a fundamental paradigm. In general, those patients are not treated. But over the years, it was recognized that, not everybody is the same on that category. Some people may have 12% plasma cells, a little bit of an M spike, be just fine. Somebody is molding, but they have like an M spike that is 3 grams, and their bone marrow is 50% plasma cells. And they are like one step away from developing problems. So one of the ways this has evolved is back 11 years ago, the International Myeloma Working Group took the very high-risk people and claimed them to be myeloma. Say, your risk is so high that don't bother waiting. Those people should be treated. Those are people whose bone marrow is more than 60% plasma cells, or patients who have a very high, we call light chain test, because they're one step away from kidney problems, and so forth. And then what is left are still some patients with higher risk. So over the years, there have been clinical trials that compare some treatment versus no treatment, okay? And there's 2 large trials, one led by Dr. Luciano from Emory, using Revlimid, lenalidomide, for 2 years versus nothing. And they showed that patients with taking Revlimid for 2 years versus those who don't take anything, they delay the development of problems like bone disease or anemia or kidney failure. More recently, there was a trial called it's going to come to me, that compare taking nothing with taking Darzalex for 2 years, daratumumab, a monoclonal antibody. And that shows that patients who take Darzalex have a longer progression-free survival and a better overall survival than those who don't take anything. And there is a trial now ongoing, a national trial, that is using both, Darzalex and Revlimid for 2 years, and see if that is better than Revlimid alone. So I think if you have high-risk myeloma, of course, first we encourage people to enter a clinical trial. If you don't mind me asking, what clinical trial you're in? Oh yes, with Dr. Joseph, who's the principal investigator, I know. Iberdomide is like a drug that's 2 generations up from Revlimid. Iberdomide. So I thought, I encourage people to enter a clinical trial. If a clinical trial is not available for whatever reason, I think both Revlimid and daratumumab are acceptable options. And they are both, covered in guidelines. Now, they're both addressed in guidelines, so they are recommended. It's by professional societies and so forth. For high risk is more. Okay. Now, so using one of those drugs alone to treat smoldering is something that is in the guidelines, but is very
uncommonly adopted. Okay? So most doctors and most myeloma doctors are not doing it. They're not buying it. And there's a never-ending dilemma of why not. And I'll give you my concern, which is a concern that many have. When you show that Revlimid is better than nothing, daratumumab is better than nothing, all that tells me is that high-risk myeloma gets better with treatment. You are affecting people's outcome when you do some treatment. The question is, how much do you accomplish with one therapy? We're not going to get rid of it with one drug for 2 years. So are we just kicking the can down the road? It's possible. So many times people choose to watch those patients carefully. And if you see that high risk evolving, like today your M spike is 1.5, 6 months from now is 2, and 6 months later is 2.5. It's moving, right? So then you just go ahead and buy into the whole myeloma treatment. Of course, every person's circumstances are very different. Oh yeah, that's very kind of you. Thank you. I mean, if you're 82, and you have other medical problems, maybe all we need is to kick the can down the road. But if you are 50, you have 30 years of life ahead, you might be better off giving a little bit more time, watching the pace of this, and then buying into a full myeloma treatment. But it's one of those topics that is extremely controversial.
So you said you're taking Revlimid or their common choice. But you said thinking of both.
There's a clinical trial now addressing if both together are better than one alone.
Okay, that's the trouble.
Yeah.
Maybe I've asked now 3, but hopefully they're all good questions.
They are great.
We've been talking about the drugs and everything. Really, the biggest problem I think for most everybody is side effects. We're not talking about side effects. So, because I can give my personal example, I'm high risk 5 years now because of high risk, I did KRD for 3.5 years. So I was norm like cheers at the infusion center. But I've been on Revlimid now for 5 years, and I'm significant neuropathy and started having dizzy, so did some MRIs of the head just to make sure there wasn't something like that. Can you address, you're doing fine, I'm MRD negative, whatever, but when is it appropriate to say, you know what, I need to move to something else or stop because of side effects? But
yeah, talking about controversies, huh? So, I have personally had conversations about that with some of you in the room. And I'll give you a very long answer to this is, if you go back in time, why are you taking Revlimid to this day, 5 years down the road? The reason for that comes down to one clinical. I know, no, for whom I have the utmost respect. But the reason why, maintenance forever is a fixture, okay, is because of one clinical trial that was published back in 2011. So it was done in the mid-2000s, where patients received some induction treatment. Back then it was thalidomide, dexamethasone, Velcade, dexamethasone, a few Revlimid, dexamethasone, so much inferior therapy. Got an autologous transplant, and then they got randomized to nothing, because that was the standard back then. We didn't do maintenance back then, or Revlimid until progression, okay? And that study shows that when you take Revlimid, you're reducing the risk of progression by about 50% per year. And turn out to also improve survival, okay? So that became on the, went to the apex of the evidence, Revlimid forever. Now, there are a couple things to realize. When you have inferior treatments than we have now, you have more disease, right? And if you have more disease left, you have more to be helped by the maintenance, right? And we know this very clearly now. The more effective your induction is, the lower risk of progression. Therefore, there's less territory to be conquered by maintenance. The other part of that is that that maintenance on the clinical trial was done, quote unquote, until progression. In real life, the average duration of Rev maintenance, even if you try to do forever, is 2 years, because people run into the problems that you're running into, okay? There is another very elegant study done in the UK that compare Revlimid versus no maintenance, that shows very clearly that the impact of maintenance declines year by year, okay? So if you look at people who just come out of transplant, maintenance versus no maintenance, big difference. If you look at people who make to year 1, year 2, year 3, the difference gets narrow and narrow, okay? So in general, what you see is as time goes by, the evidence to continue on it gets smaller, and the price of staying on it gets higher because you have more side effects, okay? So sometimes I have conversations like yearly with patients for 2-3 years until we stop, okay? Particularly in this day and age when the therapies are better than those patients on those trials 20 years ago that gave us Revlimid forever. So oftentimes I just continue or talk to patients on the basis of duration of therapy and side effects alone, okay? And there are people who say, hallelujah, I can't stop to get rid of this. And there are people who are very apprehensive because every morning you go take the pill and your mind gets tricked into thinking, tomorrow I'm cancer-free because of the pill I took today. When the reality is tomorrow you're cancer-free because of your 5 years of treatment. Now, to add to that discussion, we have the notion of minimal residual disease, or MRD, as you discussed, which is essentially a test that look at the bone marrow and measure one cancer cell out of a million, okay? And it is very intuitive to understand that if you have a lot of disease in your bone marrow, your risk of progression is higher than if you have little disease or undetectable disease. So over the years, we and others have shown that we can use that information to assess the risk and help inform that discussion, right? Because if you're already MRD negative, your risk of progression is very small. So there's less territory to be conquered by continue on maintenance treatment, okay? For standard risk myeloma, it has been shown that if you achieve MRD negativity and you stay MRD negative for 1 year, your risk of progression upon discontinuation is about 1 to 2% per year. What we have not yet done is showing what is the recipe for high-risk disease. Is there a period of time that is long enough that you're MRD negative that where your risk beyond that is negligible, okay? And that part is not yet polished, I'll put that way, okay? But at some point it becomes a self-fulfilling prophecy, right? I mean, you're told you're high risk properly, so 5 years ago. Here you are MRD negative 5 years later. So, you know, I'm less, anybody should be less scared of myeloma now than were 5 years ago. Now, do we have the right recipe or when to stop? No, not for anybody. It's a very nuanced discussion that takes into consideration time of therapy, disease risk, disease status, including MRD, and most importantly, toxicities, because as you pointed out, they get worse over time. Sorry, it's a very long no answer, but.
No, it wasn't a no answer, because that has been, Tom asked this question, but the ongoing thing I keep reading about is, now you've got all these newer drugs. I didn't know about this drug that's gentleman up in the front of Emory's with, but, there's no question Revlimid is, a lot of folks just can't tolerate. I've been blessed to make it 5 years, because of the high risk. I think if I was standard risk, we would have stopped at MRD.
Yeah.
But, so thank you. I don't think it was a no answer at all.
Is there test level above MRD, test level above, is there one that's 1 out of 10 million?
Yeah, so the test is a test that detects cells out to 1 to 1 million. We consider the threshold for decision to be 10 in 1 million, so 1 in 100,000.
But is there a test that goes beyond
No.
1 million?
No.
Okay.
So last question back here.
Doctor, I guess, first of all, we have once a year at the Cancer Center a seminar on Dr. Costa and several other people. Great event, also a fundraiser to support research to begin and stuff. And then the second thing is, I've been on, I signed up 7+ years ago for clinical trial. One of the best parts of that clinical trial was the RMD. Doctor alluded to. It helps you to understand where you are, what you're doing. I tried different things.
Yeah.
Not exactly basic, but because I was having a hard time, stay in my lane.
Yeah.
Get out of my lane. Say so. But this really doesn't know. See it all.
So thanks, Tom, for the plug. Almost 10 years now, when monoclonal antibodies like daratumumab was starting development and MRD technology was starting, we partnered with colleagues from other institutions and put together this clinical trial that Tom was part of that, used the best drugs available at the time and tailor the therapy to the achievement and sustainability of MRD. And there have been a bunch of other trials nowadays that combine 4 drugs and transplant, but they all have been continuous therapy. So because of that trial and the knowledge we got from that, we probably have the largest data set worldwide of patients who receive quadruple therapy, which is what you receive for drugs, transplant, and fixed duration therapy. So we can now describe, what happened to people once they stop therapy. Because all the other trials out there, people stay on therapy. So that gave us a lot of valuable information, including this 1% risk of progression that I'm quoting, come from looking at this database. So this, this trial has been reported many times before, but every year we find new things to learn from the data set as those patients do very well over the years. I'll put a plug as well. Because of that collaboration around that trial with 4 other institutions around the country, we have been able to continue partnership and do more trials. So this now became a standalone nonprofit organization called COMIT, stands for Consortium to Overcome Myeloma Through Innovative Trials. So our full name is COMIT, Clinical Trials, Myeloma Trials Innovated. It's fully organized as a 501c3 entity. And Jenny from the HealthTree happens to be on our board of directors. We have now 15 institutions and counting around the country doing those clinical trials. We have now 4 active clinical trials. And our idea is our mission is on our mission to capture the creativity that comes from myeloma physicians throughout the country, plus the innovation that comes from private entities, and do the things that are most provocative, most that can advance the field faster without being dependent on or limited by the red tape and the constraints that come, for example, from federal funding. It has been quite an adventure. It has taken the last bit of hair that I had, but it's been such a worth pursuit. We're growing very quickly. I think we're partnering with Jenny and her team. We're going to have a website presence. We want to have a lot of things in place before we go public, so to speak. But that I have a lot of faith that with this group, we're going to keep bringing, transformative trials to myeloma patients.
So I'm sure we could go for hours and you have a lot of questions, so I hate to cut it off, but I need to cut it off. Really want to thank you, Dr.
Absolutely,
Costa,
my
for
pleasure.
being here. It's been awesome. And we'll probably spend about a half hour. Like I said, I want to introduce HealthTree to you, talk a little about HealthTree. You're welcome to leave, stay.
I have the laundry to do.
The laundry, okay. He knows HealthTree fairly well.
Thank you very much for coming.
And I'm gonna hook up the TV. Oh, yeah.
Yeah.
Okay. Everybody in? Okay, 1, 2, 3. Awesome. Appreciate it. Glad whoever suggested that. Wow. Okay, I'm going to share my screen real quick. Yeah, that's fine. Where's my? Okay. So those of you on Zoom should be able to see the screen now. So real quick, I'll try not to take too much of your time. I know it's Saturday, you have a lot you want to do, but I just want to explain. I don't know how many of you have been to HealthTree's website or looked at it or sees what it has to offer. But there's a lot of things there that can help you, and they can help you answer some of the questions that you asked today, actually. So this is a picture of Jenny Ostrom. She started up HealthTree. She was diagnosed in 2010, and I was at the time working at MD Anderson Cancer Center in Houston, and she lived with us for a year while she was being treated. Oh, you don't have a picture, do you? That's weird. Hang on, what's going on? I don't know what it's doing. Okay. Now you might have a picture. There we go. Okay, thank you. So yes, so she started up HealthTree, called me up, said she needs some help. Couldn't do it alone. Thought I was perfect to help her. So I thought it'd be a weekend hobby, 2 hours a day on Saturdays or something like that. That we'd spend on this, and now it's ended up that I moved my family from Houston to Salt Lake City, Utah. Left MD Anderson and working full time on HealthTree, and we actually have about 80 employees right now in the foundation. People ask us why we're doing this. It's because 192,000 people are diagnosed every year with a blood cancer. 2 million people are living with blood cancer, and we want to help patients become decision makers, to understand your options and what the potential outcomes might be, what the side effects are, and we're here to help you with that. We'll talk about CureHub. This is where you really are able to help, and we'll explain that. In HealthTree CureHub, it's important to connect your medical records and have that information in there. And a lot of people are nervous about that or scared about that. And I just want to compare it to some things. So for example, if you fly anywhere, you use an app on your phone. When you enter the airport knows you're there. You check in with your phone. You check through security with your phone. You get onto the airplane with your phone, and all of your personal information is on your phone. And you use this app all the time, and you don't even think about it. Or maybe some of you use Venmo to send money to people. Venmo has all your personal information in it, and it's tied to your bank account with all your money. And you send money to people, and you don't think about that a whole lot either, because it's a convenience for you and it's easy. Some of us do our grocery shopping with an app. We'll pick out what groceries we want. Somebody will do that shopping for us. Some of us go to the store and pick it up. Some of us actually have a complete stranger come and deliver those groceries to our house so they know where we live. And that person has all our information as well. It's in the app. Our credit card, just all of our information's in the app. So we are sharing our information every day in all different ways. We just don't think about it so much because they offer a benefit to us. They help us, and we want to use them because it makes life easier. And that's what your data can do in HealthTree. Right now, your data is sitting in a hospital's database, and it's not doing anything for you. It's just sitting there. HIPAA was meant to be for you to have access to your data when you want it, and to share your data with whoever you want to share it for. That was the intention of HIPAA. Hospitals have made us afraid to share our data, and that they think we should just leave it where it is and nobody should touch it and just sit there. That is slowing down research. It's slowing down the progress of research and finding new answers to a cure. The P in HIPAA is portability, moving your data where you want to move it to and not just keep it there. I'm going to show you a quick video that explains that concept of HealthTree Cure Hub, your data, and how it ties into research. And hopefully those online can hear this.
My use of Cure Hub is important to me because I know that my myeloma story is not only helping me in managing my disease, but also helping researchers as they drive toward a cure.
Along with our work in patient education and community, HealthTree has developed two powerful patient portals, Cure Hub and the HealthTree Cure Hub Registry. Patients share their stories by connecting their EHRs, and researchers can not only review that anonymous data, but can reach out to patients to ask them to participate in surveys and studies. It's easy and quick to participate, and most importantly, all data shared is completely anonymous and secure. HealthTree Cure Hub has worked in partnership with organizations like Mayo Clinic, Dana-Farber, and Fred Hutchinson Cancer Center. There are a number of factors that slow today's research. One of the key ones is the availability of highly curated data. HealthTree Cure Hub is a wonderful resource for patients to come together with researchers to formulate questions that before could not be addressed. It is my sincere belief that the outcomes are better when the patients are informed and the patients are knowledgeable about their disease. The HealthTree Cure Hub is a very modern approach to address needs in the medical space of blood cancers. Patients working together with HealthTree Cure Hub will allow gathering of both clinical information, treatment information, samples, and that will also be a vehicle to interact with people like me, physician scientists. One of my focus projects is working on pathology slides from biopsies, part of the clinical data. This is a project that would take us probably 10 more years to set up at our own institution. So it's all about speed, and that's exactly what we can do together with the HealthTree Cure Hub. We rarely see opportunities like this where you can now have thousands and thousands of patients with a common interest of providing their information towards finding better solutions for their care. The literature has shown that patients can get the best care possible when they participate in clinical research. Our sincere hope is that other tumor types, other diseases will ultimately embrace models such as is being proposed through Cure Hub, with our ultimate goal of providing the cure for as many as possible, if not. Your data in HealthTree Cure Hub can be observed and used by researchers using the Research Hub, which sees the data, the real world data, anonymized. They don't know it's yours, but they can then look at the similarities and differences across a wide spectrum of diseases that help them march toward cure.
Okay. Oops, it stopped. Great. Gonna make me go through it again. So I want to talk a little bit about the research that Dr. Landgren talked about. I know this chart makes absolutely no sense to anybody, but Dr. Landgren was the second doctor that spoke. He's the one that he wants slides. And he wants to look at those slides because he wants to know exactly which genetic changes have occurred in your body. And he only has access to the patients at University of Miami. He can't go to any other hospital and say, can you send me your slides? They won't do it. But by working with HealthTree, he can have access to patients all across the country. Patients through HealthTree can give us the consent. We'll request that the slides be sent from their facility, and the facility has to send them because the patient requested it. And we'll send them to Dr. Landgren at University of Miami. He will get that slide and he will look at the exact genetic changes that are occurring. So instead of just having access to hundreds of patients that go to University of Miami, he now has access to the 12,000 myeloma patients in our database and their slides to participate in his study. That's why he was saying it would take him 10 years to get where he's gotten today in this study, and we've done it in 1 year. That's how we speed up research. So 1 year compared to 10 years is a lot. What this slide, this graphic is, so you understand what he's doing, this is for newly diagnosed patients. He's trying to figure out what is the right treatment for a newly diagnosed patient based on their genetics. Because right now it's kind of a guessing game. Let's try this combination of drugs. 3 months from now, it's not working so well. We're going to try this or change to this. And, you know, it's a guessing game to figure out which drug is going to help get your cancer, you know, to MRD negativity or into remission. So he's getting these slides. He's looking at the mutations. Each one of these red squares in this row is a patient. And this text over here, these are all genetic changes that have happened in those patients. So the second row is a second set of patients with that genetic change. So he's looking at all these patients with all these genetic changes. Down here below, in the yellow and oranges and blue colors, this is looking at VRD, Velcade, Revlimid, and Dex. He's looking at every single myeloma drug. I'm just showing VRD in this example. Those that are in yellow and orange colors, the medication did not work. It didn't do anything for them. Those in the blue colors, it did work. It put them into remission, and it helped them with their myeloma. So he knows now VRD, which genetic changes up here VRD works with and which ones it doesn't. And like I said, he's doing that with every single combination of myeloma treatment so that when he's done with this, he'll know you have this genetic change. This is the common drug combination that's going to attack that genetic change. It won't be a guessing game anymore. We'll know that. We'll know that. And I mean, do you all want to wait 10 years for that information? I know the answer to that. You don't. You'd rather wait a year for that information if you were newly diagnosed. And that's how HealthTree is speeding up research. But it takes each one of you to put your medical data to use and not let it just sit idle in a hospital's database. Quickly, just we've done over 102 studies with over 150 myeloma specialists. We're doing a lot of studies with Dr. Costa. He talked about the institution he's setting up, the nonprofit. We're working with him on that actively to get that going. We've had over 124,000 patients participate in our studies. Takes us 6 to 8 weeks to recruit. It normally takes them years to recruit. And we complete our studies in 9 to 18 months on average. And again, Dr. Landgren said that one study would take him 10 years. We have a total of 14,000 patients in the database. 12,000 of those are myeloma. The other 2,000 are lymphoma and leukemia patients, and over 80 million different data points for data researchers to look at. Real quickly, I just want to show you how you connect your medical records. So if you go to healthtree.org and create an account, you'll see this menu at the top. There's some educational things here. There's some community things here, and then there's Cure Hub. And if you just click in the little green area for Cure Hub, it'll bring you to this dashboard. And on the left-hand side at the bottom, it says Connect Medical Records. If you click on that, I'm going to delete Huntsman because that's the one I'm going to connect to. So Intermountain's a healthcare facility in Utah that I'm connected to. But if I want to connect Huntsman Cancer Center, it's the main cancer center in Utah, I click on Add New Connection, and I type in the name of my facility. You can type in the state or the zip code or the city. You can type in the name of your doctor. Like if you type in St. Luke's, There's hundreds of St. Luke's all around the United States. So you're gonna get a big, long list of hospitals to look at. So that's why we put in the location and the doctor's name to narrow your list down. But you don't have to enter anything in there. I'm just gonna enter Huntsman Cancer Center. I say search. It's going to find Huntsman, and you can see it right there. And I click on it. When I click on it, it's going to tell me what it's going to do, but I'm going to go because I'm going to tell you what it's going to do. We're going to leave HealthTree, and we're going into Huntsman Cancer Center's portal at this moment. They use Epic, so it's going to be my chart, and this is Huntsman Cancer Center's my chart portal. I enter my username and password. This information does not come back to us. We don't know your username and password. You click sign in, and it's going to tell you you're going to connect your medical information with HealthTree. HealthTree said we won't sell your data, we won't market it, we won't use it without your permission. It'll give you some information on that. When you click continue, it's going to show you all the information that will come to HealthTree. It's a lot of information. It's everything except your billing information. So we won't get credit cards or we won't know anything about your bills. Everything else comes in. If your hospital's on an Epic system, you pick how long you want this connection to stay intact with HealthTree. If your hospital's on a Cerner system, it stays connected forever until you delete it in HealthTree. So I would suggest if your hospital's on an Epic system, you pick 3 months so you don't have to keep redoing this connection over and over and over. When you say allow access, it's now going to leave the Huntsman portal and take us back to HealthTree. And you can see now I have Huntsman here, and it's in process of downloading the information into HealthTree. You, at any point, have the option to delete that information. It's like I said, HIPAA was meant for you to use your data how you want to use it. If you want to delete it, you can. If you want to leave it there, you can. We don't consider it our data. It's your data, and you can do what you want with it. Just a few things. I mean, in this track my disease section, this little arrow, this is where you'll see all the information that's coming in from your records. If you're going to more than one place, connect them all. When I was working at MD Anderson, the average patient was seeing 3 different doctors. So the patient comes to MD Anderson, and that doctor's seeing about 1/3 of their data and trying to make treatment decisions off of that. So if you go to multiple places, connect them all, and you'll see everything in one place. You won't have to go to different portals. You can see all your labs in one place. You can see all your genetic testing if you've had that done in one place. It'll show you what's going on with your genetics and how they're changing. Your imaging, you'll be able to see all that. What I really want to show you is treatment options. By sharing your data, it helps the researchers, but we also want to give back to you. So we have treatment options, and we use AI to look at your medical information, and it's going to show you the treatments that you're eligible to receive. If you have a kidney problem or a heart problem, there's certain myeloma medications that will make that worse. Those drugs won't show up. If you took a drug that had the side effects were so bad you stopped it, that drug isn't going to show up. But it will show the drugs you can have. You can see them. You can click on it where it says expand. It's going to show you the results of that drug. So 39% of the patients on this particular one, they had a complete response. They went into remission. So you can look at some of the statistics of these treatments. You can look at the side effects. 51% had neutropenia, which I think is low white blood cell count. 16% got infections. So you can look at some of the side effects you might experience if you were to go on this treatment. I was in San Jose about a month ago. Let me find this drug right here. I was talking to a gentleman. He's fairly young. I think he's about 47, newly diagnosed. His doctor put him on this triple combination, carfilzomab, lenalidomide, and dexamethasone. And that's what he was taking, and he was having pretty good results. We looked that up in the system, and we looked up the results, and a survival rate of more than 2 years and progression-free survival of 2 years, MRD negativity, like these are all pretty high numbers for this drug that's added this fourth one. When we looked it up for just the 3 drugs, these numbers were a lot lower. And he saw this by adding isatuximab. I'm not good at pronouncing them. I think it's Sarclisa is the brand name. Just adding a 4th drug, like the MRD negativity went from 47% up to 68% by adding that one drug. So he can come in here, or you can go in here and look at these treatments that you're eligible for and look at these percentages to see if there's one that you find interesting, that one that you might want to talk to your doctor about. You can click on Save Treatment right here. Up at the top, there's a Save Treatment option, and you can see the ones you've saved. There's an app you can download from the Apple Store, the Google Store. You put it on your phone, go to your doctor, pull it up and say, hey, I've been looking at these 3 treatments. What do you think about them? Let's talk about it. Here's what I'm seeing. You know, what are you seeing? And your doctor will have a conversation with you about it. Dr. Costa will tell you he would rather patients come in educated and know what we're talking about versus him just saying, we're going to do this treatment and have you know nothing about it. If your doctor is intimidated with you coming in with information, you should change doctors, because they should not be intimidated by you being an educated patient. And I can tell you, myeloma specialists crave educated patients. They want patients who know about this kind of stuff. They want to have these conversations with you and make decisions together with you. They want you to be happy with what treatments you're having and that sort of thing. And some people want to have a better quality of life. So they'll look at the side effects and see which one will have least side effects to have a better quality of life. So that's just a little bit about what we can give to you. If you connect your medical records, there is a clinical trial finder. It'll do the same thing. It's going to find, there's thousands of myeloma trials out there. The average patient qualifies between 5 to 10 trials. Most doctors don't have time to do all the research to find the clinical trials that you qualify for. They know the ones they know about. If you qualify for that one, they're going to say something about it, but they don't. Those that do the research, it's at home at evenings. It's taking time away from their families, and they just don't have the time. So with HealthTree, it'll do the matching for you. There's a whole bunch of test data in this, what I'm showing you, so it shows weird results. So I'm going to go to all trials. But if you see an excellent match, you know you meet the criteria for that trial. That's a trial you can join. Strong match. So there's something in there that is not a match. And if you click on it, you'll see the green checks on what you match. You'll see the triangle on what you don't match. So you have to have had a CAR T therapy to qualify for this trial. Maybe it's a great trial for you. Maybe your doctor is considering a CAR T. Maybe you do a CAR T and then you qualify for this trial after that. It's just a tool to research a little bit, to help you research so that you know what your options are. There's a twin machine. When Jenny was first diagnosed, she wanted to find someone 5 years ahead of her, and she wanted to know what they did and if it worked or not. So the twin machine matches you when you were diagnosed, your age, your genetics. It matches you to other patients in our system that are an exact match to you. And it brings them up, and you can click on that patient and you can see what treatments they had, and you can see what their genetics were and look at those. And maybe your doctor's thinking of putting you on POM. You're not sure if you want to. Up here, you can click on message and you can start a chat with that patient about POM and ask them the questions that you might have about POM and what their experience was, and if they do it again, or whatever you want to ask, you can have a conversation with the patient about that. So that's what we created the twin machine again, as a research tool. I know a lot of people I hear from are patients over 70 that their doctor wants them to do a stem cell transplant and they're nervous about it. So they'll come in here and find a patient that's over 70 that's had a stem cell transplant and start a conversation with them to see what it was like, to see if they would do it again or if they would just do treatment. And again, it's a tool to help you understand your options and help you decide what you think you want to do. The research, so this is all of the research that we're doing with myeloma specialists all around the country. There's a lot of research that we're doing. Dr. Costa talked about, and it came up about, oh, she left, about supplements and nutrition. The doctor he was talking about in New York is Dr. Urvi Shah at Memorial Sloan Kettering. So she's doing that research project with us. You can sign up with us. They actually send food to your house and you have to eat that. You have to commit to eating specific plant-based diet for a month. And the fun part of it is you also have to send them a stool sample so that they can evaluate things. But that's how they're finding out what effect diet has on myeloma. How we speed it up again. There was a doctor that, very, very simple question. He was in Chicago. He wanted to know, people that had a stem cell transplant, were there any differences between those that got the childhood vaccinations over again and those that did not? It was like 6 questions, it took a minute to answer. In 2 years, he was able to get 50 people to answer those questions. It's because he only had access to the patients that came to his clinic. He found us, this was in about 2021. He found us and said, hey, can I put my questions on your site? And we said, of course. So we put his questions on our site. In 3 weeks, he had over 1,000 patients answer that question about vaccinations. That's how we're speeding up research. And by the way, the results of his research were those that got the childhood vaccinations after stem cell transplant had fewer infections, pneumonia and colds. And now there's other researchers that are taking, he's published on it. The other researchers are taking his research and digging in deeper to it. So there's going to be more research coming out about that. So this is how you can get involved. You know, cancer is hard, and I mean, I don't have it, so I don't know exactly how you all feel, but I MD Anderson for 12 years. I've talked to a lot of patients, HealthTree for 6 years. I've talked to, just this year, I've talked to over 900 patients doing things like this, doing different events. It can feel like it takes over your life. And this is how you can feel like you can take some control back. You can participate in this research. You can let researchers use your data for whatever research they're doing. We never give any of your personal information to anybody. So they won't know who you are. They won't be able to contact you or find you. So it's all de-identified data. Every bit of personal information is removed from the data that's shared with researchers. We share it with them for free. We don't charge them because we want it to happen faster. So that's a real quick overview of HealthTree Cure Hub and what you can do. Any questions about any of that? Is it something you feel like you're interested in doing or would want to do? Are you nervous about sharing your medical records?
Not now.
That's the common answer I get.
Before, I was just a stalker. And now
Awesome. I appreciate that. Yeah, like I said, the more data we get, the more researchers can do with it, and the more things they can find out, and the more answers they can get, and the quicker we can find a cure. We believe a cure is out there. The CAR T therapy and the bispecifics that Dr. Costa talked about, there are some doctors that are starting to call those 2 types of treatments a cure. If you go longer than 5 years with MRD negative, they consider you cured, and there are some patients that have gone that long. A lot of doctors still aren't ready to say there's a cure. So, you know, it's a mixed field. There's a lot that said, no, there's not a cure for myeloma, but there are a few that are starting to say, we're going to cure this. and this is what it takes. And they're coming to us because they know they can make things happen faster. Like the drugs that are coming out to market recently, so the bispecific drugs, they started 17 years ago. That's how long it takes them to get through the process from beginning to being available for you as a patient to take. We can cut that in half or more. And that's what we're doing and what we want to do. So I hope you'll join. I hope you'll connect your medical records. It is important, and you play an important role in this. It can't be done without you. It just can't. So I appreciate you all coming. I know you all came for Dr. Costa, not for me or HealthTree to learn about this, but hopefully this taught you a little bit, and you'll go home and go to healthtree.org and create an account and play around. There's a lot of aspects to it, the community aspects. There's a free coach program. We have 200 coaches coaching 2,000 patients. They're myeloma patients or caregivers of myeloma patients. There's a Connect program. It's kind of like Facebook, but it's tailored just to cancer with different topics. So there's lots of other educational resources out there for you. Another popular one is HealthTree University. Thousands of videos from myeloma specialists all around the country talking about all different topics. So if you're wondering about supplements, if you're wondering about treatments, if you're wondering about labs, smoldering, should I have treatment? Should I not? Should I wait? There's videos out there in HealthTree University with myeloma specialists talking about all of that you can go listen to. So thank you again all for coming. Appreciate it. You're welcome. If you have any questions, I do have a business card up here. It has my email address on it. If you come get one from me, and I'm happy to email me directly, and I will help you in any way I can. I'll probably reach out in a couple of weeks to see if any of you need help and want help with connecting medical records. Like, again, not mandatory. It's your information. You are allowed to do what you want with your information. So thanks again. Oh, just a sec. Let me finish. All of you online, thanks for joining. Appreciate it.